Welcome to this custom-tailored deep dive. We are so glad you are here with us today. But do not worry, because you do not have to read through thousands of pages of dense pathology yourself. We have done the heavy lifting for you.
Exactly. We have combed through every chart, every diagram, and clinical protocol to extract the absolute most important, life-saving nuggets of respiratory knowledge. Whether you are a healthcare student prepping for your licensure exams like the NCLEX, or simply someone who possesses a pair of lungs and wants to understand the incredible mechanics of the human body, you are in the right place.
Our mission today is to give you a shortcut to being a respiratory system master. We are cutting through all the jargon to find those true aha moments about how we breathe, what happens when those mechanics break down, and precisely what clinicians do to fix them. And I think the best place to start is with the fundamental assessment. Like, what are we looking at and what are we listening for?
Right.
That in critical care, understanding the why dictates the how. I mean, memorizing symptom lists is just insufficient. When you understand the pathophysiology, the mechanical and chemical failures driving the disease, the correct clinical intervention naturally follows.
That perfectly aligns with the ultimate priority rule detailed in the sources, the ABC framework: airway, breathing, and circulation.
Exactly. This is used during multiple alarm scenarios. What is going to kill this patient first?
It is blunt, but it works. The textbook excerpts back this up by emphasizing that acute physiological derangements always supersede chronic ones.
Always. Unstable presentations dictate immediate action over stable baseline abnormalities. Every single time.
So if a patient presents with an acute airway compromise, assessing their, peripheral edema or checking their glucose levels is totally irrelevant unless those factors are directly threatening the airway.
Right. Consider a chronic COPD patient who maintains a baseline oxygen saturation of, say, 89%. Their physiology has adapted to that state. They are clinically stable.
They take a backseat to an asthmatic patient presenting with sudden, severe bronchoconstriction and impending respiratory failure.
Absolutely. What is fascinating here is how the body signals an airway threat. Let's look at pediatric patients. Their airway diameter is already anatomically narrow.
The texts highlight epiglottitis and croup as primary examples. Epiglottitis is usually a bacterial infection that severely inflames the supraglottic structures.
And the clinical presentation is unmistakable. You have acute onset of high fever, severe dysphagia leading to drooling, and the child adopting a tripod position just to maximize airway patency.
Drooling is a huge red flag. And here is a massive NCLEX alert for you listening. The literature is unambiguous here. Introducing a tongue blade to visualize the airway is strictly contraindicated.
Never do it. The sheer reactivity of those inflamed tissues is wild. Mechanical stimulation of a highly edematous epiglottis can trigger instantaneous laryngospasm,
which results in complete airway occlusion.
Right. The protocol is to secure the airway via intubation in a controlled setting before any physical examination of the oral cavity.
Now, croup, conversely, is typically viral. The inflammation is subglottic,
which produces that classic seal-like barking cough.
Right, and with croup, you frequently observe inspiratory stridor, indicating significant narrowing of the upper airway. Stridor means upper airway priority. But beyond anatomical obstructions, we have the cellular threat of hypoxia.
This is where we see a huge common mistake. A common misconception is relying on cyanosis, that bluish discoloration of the skin and mucous membranes. People think that is a primary early indicator of oxygen deprivation.
The medical texts emphasize that cyanosis is a profoundly unreliable early metric.
Cyanosis is a severely late indicator of hypoxia. By the time desaturated hemoglobin levels are high enough to produce visible cyanosis, the patient is already in profound physiological distress.
They're crashing by that point. The early signs of hypoxia are entirely neurological. The cerebral cortex is exquisitely sensitive to oxygen deprivation.
Exquisitely sensitive. Before you see changes in skin color, you will observe neurological deterioration, acute restlessness, irritability, and unexplained confusion.
That is a critical takeaway for you. Another NCLEX alert. If a patient suddenly becomes agitated or combative, attributing it to anxiety or hospital delirium is a dangerous pitfall.
Their cortical tissue might literally be starving for oxygen. Assessing airway patency and oxygen saturation must be your immediate reflex.
Because recognizing those early neurological deficits dictates the intervention. You secure the airway and optimize oxygen delivery before irreversible cellular damage occurs. Airway first. Oxygen first.
Right, and because ensuring oxygenation is the absolute priority, we have to carefully assess the mechanical function of the lungs. Which brings us to auscultation.
Yes, the lung sounds. The registered nurse transcripts categorize adventitious lung sounds based on their underlying mechanical causes. It is like a bizarre symphony. Let's break down crackles or rails.
So these are subdivided into fine and coarse crackles. Fine crackles are high-pitched popping sounds. It is analogous to hair being rolled between the fingers right near your ear.
The physical mechanism generating that sound occurs at the alveolar level. In conditions like early congestive heart failure or pulmonary fibrosis,
Fluid or fibrotic changes alter the surface tension within the alveoli, causing them to collapse during exhalation.
and then when the patient inspires, those sticky, deflated alveolar sacs forcefully pop open, pop, pop, pop.
Exactly. Coarse crackles represent a completely different pathophysiology. They are lower-pitched, bubbling, or gurgling sounds.
Which indicates fluid or thick exudate accumulating in the larger airways, such as the bronchi. We hear coarse crackles in severe pneumonia or pulmonary edema.
And notably, unlike upper airway secretions, these coarse crackles typically do not clear with coughing because the fluid is deeply settled in the bronchial tree.
The presence of coarse crackles tells you the patient's ability to clear their own secretions is compromised. They might need deep suctioning, but here's where it gets really interesting. Wheezes.
We categorize wheezing as a continuous musical sound resulting from bronchoconstriction.
Applying Poiseuille's law, as the radius of the airway decreases due to smooth muscle spasms and asthma, the velocity of the air forcing its way through that narrowed lumen increases.
Creating that high-pitched whistle. And this physiological reality sets up one of the most dangerous clinical traps in respiratory medicine: the silent chest.
This is a huge one.
In the middle of a severe asthma exacerbation, a patient will be visibly dyspneic, using accessory muscles and exhibiting loud bilateral wheezing. If that wheezing abruptly ceases, but the patient's work of breathing remains severe, it indicates a catastrophic progression.
Which completely subverts your basic instinct. Your instinct is that silence equals relief, but here silence equals a total obstruction.
The airways have constricted so severely that tidal volume has dropped near zero. No airflow means no sound. It is an immediate precursor to respiratory arrest.
Recognizing that silence is the trigger for emergency pharmacological intervention and potential intubation. Rounding out the adventitious sounds, we have raunchy,
which present as deep, low-pitched snoring sounds, generated by thick mucus strands in the trachea or large bronchi, and they frequently do clear or shift after a strong cough.
Then we have the pleural friction rub, which sounds like pieces of dry leather grating against each other. Normally, the pleural layers glide friction-free, but in pleuritis, that fluid is lost. The inflamed pleural layers grind together, producing severe localized pain during inspiration.
Because we understand the mechanics behind these sounds, we can select the appropriate oxygenation devices. The texts detail an escalating ladder of oxygen delivery.
Nasal cannulas provide a low fraction of inspired oxygen, or FiO2, at 1 to 6 liters per minute. For severe hypoxemia, the non-rebreather mask utilizes an attached reservoir bag to deliver an FiO2 approaching 100%.
The critical safety parameter, and a very common exam trap, is with the non-rebreather. You must maintain sufficient flow to keep that reservoir bag at least 2/3 inflated during the entire respiratory cycle.
If the flow rate is too low and the bag fully collapses during inspiration, the patient begins rebreathing their own exhaled carbon dioxide, exacerbating hypercapnia. You could suffocate them.
To avoid unpredictable FiO2 fluctuations, we use the Venturi mask. It relies on the Bernoulli principle. It allows for precise, fixed oxygen delivery,
which is non-negotiable when managing a very specific patient population: those with chronic obstructive pulmonary disease. Let's dissect the COPD paradox.
The pathophysiology here is a masterclass in adaptation. COPD destroys the alveolar walls. The lungs lose their elastic recoil. They can inflate, but they lose the passive elastic snap required for exhalation,
leading to chronic air trapping and a barrel chest. This air trapping results in chronically elevated arterial carbon dioxide levels.
In a healthy physiological state, an increase in CO2 is the primary stimulus to breathe. But the COPD patient lives in a state of chronic hypercapnia.
Over time, their central chemoreceptors become completely desensitized to the elevated CO2. Their hypercapnic drive is blunted.
So the body adapts by shifting reliance to the peripheral chemoreceptors, which monitor oxygen levels. This is the hypoxic drive. Their primary stimulus for respiration becomes a loss of oxygen.
Which brings us to another massive NCLEX alert. Administering high-flow, uncalibrated oxygen to a severe COPD patient suddenly raises their PaO2.
The peripheral chemoreceptors sense the abundance of oxygen and signal the respiratory centers to decrease the respiratory rate.
You essentially shut off their drive to breathe, precipitating acute hypoventilation and potential respiratory arrest.
Because COPD patients live in that delicate balance, monitoring their exact internal chemistry is mandatory. And that brings us to the ultimate diagnostic tool, arterial blood gases, or ABGs.
Let's keep the shortcuts minimal but powerful. The normal parameters are tightly regulated, pH between 7.35 and 7.45, PaCO2 between 35 and 45, and bicarbonate, or HCO3, between 22 and 26.
The clinical utility of the ABG lies in its ability to pinpoint the exact nature of an acid-based arrangement. Carbon dioxide functions as an acid in the blood.
When the respiratory system fails to adequately ventilate due to COPD, pneumonia, or opiate-induced respiratory depression, CO2 accumulates above 45.
If we connect this to the bigger picture, this accumulation of acid drops the systemic pH below 7.35, resulting in respiratory acidosis.
We also have to look at uncompensated versus compensated respiratory acidosis, which the textbooks stress heavily.
When a patient presents an acute respiratory failure, their ABG will show a low pH and a high PaCO2, but a completely normal bicarbonate level. This is uncompensated respiratory acidosis.
The term uncompensated highlights the temporal limitations of our metabolic system. The kidneys are responsible for metabolic compensation. They can reabsorb and synthesize new bicarbonate to buffer the acid.
However, renal compensation is a slow process. It takes 24 to 48 hours for the kidneys to significantly alter bicarbonate levels.
So an uncompensated ABG tells you this is an acute crisis. The lungs have just failed, and the kidneys haven't had the necessary 2 days to ramp up their bicarbonate production. Moving from diagnosis to intervention, let's look at medication exam traps.
The pharmacology of bronchodilators is highly specific. Albuterol, a short-acting beta-2 agonist, is the primary rescue medication. It causes immediate relaxation and bronchodilation to reverse an acute asthmatic spasm.
Maintenance therapies require a different mechanism. Salmeterol provides long-acting beta agonism. An NCLEX trap is seeing a student select a LOBA, like salmeterol, for an acute attack. It will not work fast enough.
Exactly. Elimination strategies demand you cross out long-acting meds for acute shortness of breath, and inhaled corticosteroids like fluticasone target the underlying inflammatory cascade over time.
The sources strictly mandate a specific sequencing protocol when both a bronchodilator and a corticosteroid are prescribed.
The physiological logic dictates administering the bronchodilator first. You must achieve smooth muscle relaxation and widen the airway lumen initially.
Waiting several minutes allows for maximal bronchodilation, ensuring that the subsequently inhaled corticosteroid can penetrate deeply into the distal airways and alveoli.
And regarding those corticosteroids, preventing local immunosuppression is key. Patients must thoroughly rinse their oral cavity post-inhalation to prevent the overgrowth of candida, which manifests as oral thrush.
Now, expanding on infectious protocols, the textbooks dedicate significant space to tuberculosis. TB is transmitted via aerosolized droplet nuclei,
which are small enough to bypass the respiratory defense mechanisms and remain suspended in ambient air for extended periods. This mandates strict airborne precautions.
Placing the patient in a negative pressure room to prevent contaminated air from entering the hospital corridors and requiring staff to use N95 respirators.
The pharmacological management of TB involves a multi-drug regimen. The texts highlight a notable side effect trap regarding rifampin.
It alters the color of bodily excretions, turning tears, sweat, and urine a vibrant orange. While clinically benign, anticipating and educating the patient about this prevents severe distress.
There is also a crucial diagnostic nuance regarding TB screening that traps many clinicians. The standard PPD skin test measures delayed hypersensitivity.
However, many individuals born outside the United States receive the BCG vaccine early in life. Because it contains a live attenuated strain, it sensitizes the immune system.
Which means if you administer a PPD test to a BCG vaccinated patient, they will mount an immune response, producing a false positive induration.
To avoid this, the protocol dictates bypassing the skin test entirely and utilizing an IGRA blood test or a chest radiograph to accurately determine the presence of active disease.
Shifting to mechanical therapies, we must differentiate between two essential bedside tools, the peak flow meter and the incentive spirometer.
A peak flow meter measures forced expiratory volume. Asthmatic patients use it to track airway patency during exhalation.
The incentive spirometer focuses entirely on inspiration, Postoperative patients are prone to basal atelectasis due to shallow breathing from surgical pain.
By inhaling slowly and deeply to raise the internal piston, the patient generates significant negative intrapleural pressure, forcefully reopening those collapsed alveoli and mitigating the risk of postoperative pneumonia.
This concept of manipulating intrapleural pressure bridges perfectly to the mechanics of chest tube drainage systems.
So, what does this all mean when you are standing at the bedside evaluating a chest tube unit? The physiology of the pleural space relies on maintaining negative pressure to keep the lungs expanded against the chest wall.
A chest tube system reestablishes that negative pressure after a pneumothorax or hemothorax. The diagnostic window of the system is the water seal chamber.
During normal respiration, you should observe tidling, the water level gently rising during inspiration and falling during exhalation. Tidling confirms the system is patent and functioning.
Intermittent bubbling in the water seal during exhalation or coughing is expected if you are evacuating a pneumothorax.
However, continuous, vigorous bubbling in the water seal chamber is a pathological sign.
Continuous bubbling indicates a breach. Atmospheric air is entering the system, either via a loose mechanical connection or because the chest tube is migrated.
In the event of a catastrophic system disconnection, where the tube detaches from the drainage unit, atmospheric air can rush directly into the chest cavity, causing immediate lung collapse.
The emergency protocol requires rapid application of physics. You immediately submerge the distal end of the chest tube into a bottle of sterile water.
This creates a temporary rudimentary water seal. The positive pressure of a patient's exhalation can push trapped pleural air out through the water, but the water's hydrostatic pressure prevents ambient room air from traveling back up the tube during inspiration.
Managing pressures is also the fundamental challenge of mechanical ventilation. Ventilators monitor airway resistance and compliance through specific alarms.
A high-pressure alarm indicates the machine is encountering increased resistance during the inspiratory phase. This suggests acute bronchospasm, a mucus plug occluding the tube, or the patient actively biting the tube.
Conversely, a low-pressure alarm means the ventilator is delivering tidal volume but encountering zero resistance.
The air is escaping the closed circuit, almost universally indicating a disconnection in the ventilator tubing or a deflated endotracheal tube cuff.
Beyond alarms, the textbooks heavily emphasize the hemodynamic consequences of positive end expiratory pressure, or PEEP.
PEEP is a setting that maintains a baseline of positive pressure in the alveoli at the end of exhalation, preventing alveolar collapse.
But implementing high levels of PEEP transforms the normal physiology of the thorax. Normally, breathing creates negative intrathoracic pressure, which helps pull venous blood back into the right atrium.
When you apply high PEEP, you continuously maintain positive pressure within the thoracic cavity. This elevated pressure physically compresses the vena cava.
It drastically decreases venous return to the right side of the heart. If the right heart cannot fill with blood, the left heart has nothing to pump out.
Cardiac output drops significantly, leading to profound systemic hypotension. It is a prime example of how forcefully correcting a respiratory failure can inadvertently crash the cardiovascular hemodynamics.
So bringing this all together for an NGN clinical judgment approach, when given a respiratory case, you systematically break it down.
First, identify the worst assessment finding. Is it the drooling, the stridor, the silent chest?
Second, identify the immediate threat. Is the airway occluding right now? Is it an acute uncompensated acidosis?
Third, eliminate non-priority options. Do not check a blood sugar if the patient has a barking cough and stridor.
And finally, choose the intervention that improves oxygenation first. Sit them up, apply oxygen, prepare for intubation if necessary.
It all comes back to physiological prioritization. Assessing the airway first, recognizing that acute instability supersedes chronic adaptation. Hypoxia manifests neurologically long before cyanosis appears.
And managing oxygenation requires understanding the precise mechanics of your gear, from the Venturi masks to the risks of blunting the hypoxic drive in COPD patients.
Interpreting ABGs requires understanding the delayed metabolic compensation of the kidneys versus the immediate failure of the lungs.
This raises an important question, however, looking beyond current textbook pathology. The sources document occupational lung diseases. Conditions like silicosis and asbestosis, where decades of inhaling industrial particulate matter cause severe pulmonary fibrosis.
Given the exponential rise of aerosolized microplastics, novel synthetic polymers, and concentrated urban pollutants, what unidentified restrictive lung diseases is the modern population silently incubating?
Decades from now, what entirely new categories of occupational and environmental lung disease will the textbooks be forced to define? It is definitely something to think about.
That is a profound physiological implication to consider. Our environmental exposures might be outpacing our evolutionary defenses.
Because going through
This podcast is brought to you by NCLEX-ReviewPro, your trusted platform for smarter, high-yield NCLEX-RN preparation. Our motto, prep like a pro. Let the worries go. Visit NCLEXReviewPro.com to explore all resources.
this information, I realize a lot of what we think we know from pop culture is completely backwards, especially when it comes to oxygen deprivation.
Okay, let's unpack this. We always see people turning blue on TV.
You're likely thinking of cyanosis, yes, that classic cinematic sign where a patient's lips or fingers turn blue. It is a very common misconception that this is the first thing you should look for. In clinical reality, waiting for a patient to turn blue is a dangerous game.
Because it's too late by then.
Exactly. Cyanosis is actually a very late sign of hypoxia, which is low oxygen in the tissues. To understand why, you have to look at how the body prioritizes its resources. The brain is an absolute oxygen glutton.
It takes everything it can get. It does. It is exquisitely sensitive to even the slightest drop in supply. So long before the skin or the mucous membrane start to change color, the brain begins sending out massive alarm signals. The brain panics first. That is why the early signs of hypoxia are mental and behavioral.
So you're going to see restlessness, anxiety, agitation, and a sudden onset of confusion.
Yes. If you are ever observing a patient or even a family member and they suddenly become combative or highly disoriented out of nowhere, your first thought shouldn't necessarily be that they are having a psychiatric issue. Your first diagnostic question needs to be, is their brain getting enough oxygen?
Time for a quick clinical coach moment. On the NCLEX, this is a huge priority question. The very first sign of hypoxia is almost always restlessness. If a question asks when to notify the provider or when to increase oxygen, look for that sudden change in mental status. That shifts the whole perspective, right? We are looking for behavioral distress before physical discoloration.
Absolutely.
But we also have technology to help us quantify oxygen levels, like the ubiquitous pulse oximeter that clips onto your finger to measure SpO2. However, the medical guides emphasize a major, potentially fatal pitfall here. That little machine can easily be tricked into giving a perfectly normal reading when a patient is actively suffocating.
It is a terrifying illusion if you don't understand the underlying technology. A pulse oximeter works by shining a specific wavelength of light through the capillary bed, which is the tiny network of blood vessels in your finger. It measures the percentage of hemoglobin that is saturated.
Okay, so think of hemoglobin as a bus.
That's a great analogy. It's a bus that travels through your bloodstream, and its seats are designed to carry oxygen molecules. The machine simply counts how many seats are occupied.
But the machine is essentially blind to who is sitting in those seats. And that brings us to carbon monoxide poisoning.
Precisely. Hemoglobin actually has a much higher affinity for carbon monoxide than it does for oxygen. It binds to carbon monoxide about 200 times more tightly. Carbon monoxide is like a nightclub bouncer, letting the wrong VIPs into the club and locking the doors.
So no oxygen can get in.
Right. If a patient has been exposed to carbon monoxide, those hemoglobin buses will be fully occupied by the toxic gas. The pulse oximeter will read 98% or 99%, making you think the patient is perfectly oxygenated while their actual cells are starving to death. The golden clinical rule is treat the patient, not the monitor.
Treat the patient, not the monitor. That makes perfect sense. So beyond looking behavior and questioning the machines, we have to listen. The diagnostic materials outline 4 main adventitious or abnormal breath sounds, and they paint a really vivid auditory picture. Let's decode them. The first is stridor.
Stridor is a harsh, high-pitched, vibrating sound, typically heard when the patient breathes in. It sounds almost mechanical, and it is a massive red flag. Stridor indicates an upper airway obstruction,
Which is an absolute emergency.
a drop-everything emergency. Think of conditions like croup in young children or epiglottitis, where the flap of tissue protecting the windpipe swells up so much it blocks the airway entirely.
The notes mention a classic visual cue for epiglottitis. It's a patient who is actively drooling because their airway is so swollen they literally cannot swallow their own saliva.
Yes, if you have a patient with stridor and they are drooling, you do not force them to lie down and you do not stick anything in their mouth to look. You immediately call for emergency airway support.
Next on the list of sounds, we have wheezes. We hear about this a lot with asthma.
Wheezes are musical, squeaky sounds, almost like a whistle. They happen when air is forced through a narrowed, constricted passage. In an acute asthma attack, the airways are inflamed and the smooth muscle is in spasm, clamping down. You will typically hear this whistling sound most prominently when the patient is exhaling, trying to push air out through those tight pipes.
Then we have crackles, which the pathology notes describe as fluid popping in the alveoli.
The alveoli are the tiny balloon-like air sacs at the very end of the respiratory tree. This is where the actual swap of oxygen and carbon dioxide happens. If those microscopic sacs fill with fluid, which is exactly what happens in pneumonia or congestive heart failure, they stick together.
Oh, wow.
Yeah, so when the patient takes a breath in, the air forces those wet sacs to pop open. It sounds remarkably similar to taking a strand of hair and rubbing it between your fingers right next to your ear.
Yeah, it is a great way to remember it. Finally, we have raunchy.
Raunchy are low-pitched, continuous sounds. They sound like a deep snore or a moan in the chest. This indicates thick secretions or mucus in the larger main airways.
And what's interesting here from a clinical intervention standpoint is that, unlike crackles, which are deep in the tissue, raunchy can often be cleared mechanically, right?
Exactly. If you have the patient take a deep breath and give a strong, effective cough, that snoring sound will frequently disappear.
We've touched on asthma when discussing wheezing, which naturally transitions us into the mechanics of obstructive disorders. The material spent a massive amount of time contrasting asthma and COPD. Mechanically, the distinction comes down to reversibility versus permanent structural damage.
That is the core of it. Asthma is a reactive airway disease. The airways hyperreact to a trigger, like an allergen, cold air, or stress, and they clamp down. But once the trigger is removed or the right medication is applied, the airways can relax and return to a completely normal baseline. COPD, which primarily encompasses emphysema and chronic bronchitis, is progressive and chronic.
So with emphysema, the actual architecture of the lungs is destroyed. The alveoli lose their elasticity, becoming baggy and floppy, which traps stale air inside.
Exactly. And with chronic bronchitis, you have a permanent state of inflammation and excessive mucus production. You cannot simply reverse COPD. The clinical management is entirely different.
Here's where it gets really interesting. This brings us to one of the most fascinating physiological adaptations in the entire body, the hypoxic drive. The way the clinical guides explain this oxygen paradox is incredible.
It is a brilliant example of the body's resilience, but it also creates a major trap for well-meaning medical professionals. To grasp the hypoxic drive, you first need to know how a healthy respiratory system works. In a healthy person, the primary trigger to take a breath isn't a lack of oxygen. It is an excess of carbon dioxide.
Right. CO2 acts as the thermostat. When it builds up in the blood, it makes the blood slightly acidic, and the brain's chemoreceptors sense that and command the lungs to take a breath and blow the CO2 off.
But a severe COPD patient has broken that thermostat. Because their lungs are structurally damaged and trap air, they chronically retain CO2, their CO2 retainers. Their baseline level of carbon dioxide is always abnormally high. Over years, their brain's receptors become blunted and desensitized to it. The high CO2 no longer triggers the command to breathe.
So the body has to switch to a backup system. If high CO2 doesn't tell them to breathe, low oxygen does.
Exactly. Their respiratory drive shifts completely. They breathe because their oxygen levels are slightly low. This is the hypoxic drive. Now, consider a scenario where this severe COPD patient comes into the emergency room in respiratory distress. A clinician sees them struggling, sees a low oxygen saturation, and decides to be helpful by throwing a high-flow, 100% oxygen non-rebreather mask on their face.
Which floods their system with oxygen. And because their brain relies on low oxygen to trigger a breath, that sudden flood of oxygen essentially tells the brain, hey, we have plenty of O2, you can stop working so hard.
Precisely. You completely knock out their drive to breathe. Their respiratory rate plummets, they retain even more toxic levels of CO2, and they can quickly slip into CO2 narcosis, coma, and respiratory arrest. The treatment actually causes the failure.
Here's a huge NCLEX alert. The standard protocol for a severe COPD patient is a target SpO2 typically between 88% and 92%. You deliver oxygen carefully, often using a Venturi mask for precision delivery so you don't give them that dangerous flood.
That is exactly right.
Knowing how delicate that balance is makes the pharmacology side of things even more critical. The medical protocols divide the inhalers for these obstructive disorders into two strict categories: rescue and maintenance.
Rescue inhalers are your emergency brakes. The most common is albuterol, which is a short-acting beta agonist. During an acute asthma attack or COPD exacerbation, the smooth muscle around the airway is in spasm. Albuterol works rapidly to relax that muscle and dilate the airway. But it does this by stimulating the sympathetic nervous system, your body's fight or flight response.
Which explains the side effects. If you are artificially triggering fight or flight, the patient is going to experience tachycardia, that rapid, racing heartbeat, along with tremors and severe jitteriness.
It is a systemic jolt. On the other hand, maintenance inhalers like salmeterol or fluticasone are the long game. Salmeterol is a long-acting bronchodilator, and fluticasone is an inhaled corticosteroid. You use these on a strict daily schedule to reduce chronic inflammation and keep the airways calm.
I noticed the materials are incredibly strict about the sequencing if a patient is prescribed both types of inhalers at the same time. You must use the bronchodilator first and wait a few minutes before using the steroid. And thinking about it mechanically, that makes perfect sense. If the airway is clamped shut, shooting a steroid in there is just going to hit a closed door.
That is the exact clinical rationale. You use the bronchodilator first to open the passages. Then, when you administer the inhaled corticosteroid, the medication can actually travel deep into the lower respiratory tract where the inflammation resides.
There is also a major patient teaching point regarding those steroid inhalers. Always rinse your mouth with water and spit after using them.
Corticosteroids are immunosuppressants. They reduce inflammation, but they also suppress the local immune response. If you leave steroid residue sitting on your tongue and the inside of your cheeks, you create an ideal environment for an opportunistic fungal infection called oral candidiasis, commonly known as thrush. A simple rinse and spit washes away the residue and prevents the fungus from taking hold.
Let's shift from obstructive disorders to infectious diseases and restrictive issues, because there are some truly fascinating logistical interventions here. For instance, the clinical guides mention a counterintuitive positioning trick for a patient with unilateral pneumonia, meaning the infection is isolated to only one lung.
This is a beautiful example of using gravity as a medical intervention. The standard rule is good lung down. If a patient has severe pneumonia in their right lung, you position them in bed lying on their left side.
Initially, that sounds wrong. You'd think you wouldn't want to put the heavy weight of the body on the one good lung, but it comes down to matching the blood supply with the oxygen supply, right?
Yes, it is all about optimizing the ventilation perfusion match, often abbreviated as VQ. Gravity naturally pulls blood flow down to whichever part of the body is closest to the floor. In our example, the right lung is consolidated. It is filled with infectious fluid and debris, meaning it cannot absorb oxygen. If you lay the patient on their right side, you are sending all your precious pulmonary blood flow to a lung that can't do anything with it.
But by putting the healthy left lung down against the mattress, gravity directs the bulk of the blood flow to the healthy tissue that is actually clear and capable of gas exchange.
Exactly. You are manually directing the traffic to the open toll booths.
Speaking of infectious diseases, the pharmacology section spends a significant amount of time on tuberculosis. TB is a totally different beast compared to standard bacterial pneumonia. The bacteria itself has this thick, waxy, armored coating that makes it incredibly stubborn and slow-growing.
Because of that evolutionary armor, a standard course of antibiotics won't even make a dent. TB requires a massive multi-drug siege, typically lasting anywhere from 6 to 9 months. If a patient stops taking the medication early because they feel better, the surviving bacteria mutate, leading to multi-drug-resistant TB, which is a global health crisis.
Time for another NCLEX alert on medication teaching. The primary medical regimen is remembered by the acronym RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. And these are heavy-duty drugs. Rifampin, for example, is famous for turning bodily fluids bright orange.
It is an alarming side effect if the patient isn't warned. Their urine, sweat, and even their tears will turn orange. It is physically harmless, but they absolutely cannot wear soft contact lenses while taking it, or the lenses will be permanently stained.
And isoniazid, commonly called INH, comes with a high risk of peripheral neuropathy, the tingling and numbness in the hands and feet.
INH actively depletes the body's stores of vitamin B6, which is crucial for nerve health. To counteract this, patients on INH are almost universally prescribed a vitamin B6 supplement. Furthermore, because TB is highly contagious and spreads through microscopic aerosolized droplets that can hang suspended in the air for hours, the logistical management is intense.
Right, the patient must be placed on strict airborne precautions. This isn't just closing the door. They need a negative pressure room, where the ventilation system pulls air into the room from the hallway rather than pushing contaminated air out when the door opens. And anyone entering must wear a fitted N95 respirator mask.
You mentioned the VQ match earlier regarding pneumonia. The materials dive deeper into VQ mismatch, which is a fundamental concept in critical care. V is ventilation, or airflow. Q is perfusion, or blood flow. The lungs have a dual mandate: bring air in and bring blood by. A mismatch occurs when one of those systems fails.
So let's break down the two main failures using a traffic analogy. The first type is a shunt, where V is less than Q.
In a shunt, the blood is flowing perfectly fine, but there is no air reaching the alveoli. The airway road is blocked. This happens in severe pneumonia or pulmonary edema, where the air sacs are flooded with fluid. The hemoglobin buses drive by, but the bus stop is completely underwater, so no oxygen passengers can get on. The unoxygenated blood is simply shunted back to the heart.
The inverse of that is dead space, where V is greater than Q. Plenty of air is flowing into the lungs, but there is no blood flowing past to pick it up.
The most dangerous clinical example of dead space is a pulmonary embolism. A massive blood clot travels from the leg and gets lodged in the pulmonary artery. The patient is hyperventilating, pulling in huge volumes of oxygen, but the highway is blocked. The blood cannot reach the alveoli to pick up that oxygen.
Which brings us perfectly into the realm of high-stakes clinical priorities and emergencies. On the NCLEX, this is a priority question every single time. The absolute golden rule of prioritization across all medical disciplines is the ABC's airway, breathing, circulation.
It dictates the order of survival. You cannot fix a circulation problem, like a hemorrhage, if the patient is not breathing. And you cannot fix a breathing problem if the airway is physically blocked. Airway always wins.
The protocols highlight some intense emergencies. Let's look at a tension pneumothorax. This is when a puncture or defect allows air to enter the pleural space, the cavity between the lung and the chest wall every time the patient inhales, but it acts as a one-way valve so the air cannot escape.
The pressure inside the chest cavity builds exponentially with every breath. It acts like an inflating balloon, completely collapsing the lung on that side. But it doesn't stop there. The pressure becomes so immense that it starts physically pushing the heart, the trachea, and the major blood vessels toward the opposite side of the chest.
The physical hallmark of that is tracheal deviation, where the windpipe literally bends off-center, along with completely absent breath sounds on the affected side. That requires immediate decompression, usually followed by the insertion of a chest tube. And the guides spend a lot of time demystifying how chest tubes actually work.
A chest tube system is essentially a mechanical vacuum. It relies on a chamber filled with sterile water to act as a one-way seal, preventing room air from rushing back into the patient's chest. When assessing this system, you look at the water seal chamber. As the patient inhales and exhales, the pressure changes in their chest. You should see the water level gently rise and fall in tandem with their breathing. That fluctuation is called tidling, and it confirms the system is intact.
But continuous, vigorous bubbling in that same water chamber is a bad sign. It means you have a leak in the tire somewhere. What if the worst happens and the tube gets accidentally yanked out of the plastic drainage unit on the floor?
If the system disconnects, room air can get sucked straight into the chest, recreating the pneumothorax. Your immediate emergency action is to take the end of the tube coming out of the patient and submerge it about an inch deep into a bottle of sterile water. This creates an improvised temporary water seal, buying you time to get a new drainage system hooked up.
That is a phenomenal piece of practical logistics. Speaking of logistics, the materials offer a really fascinating look behind the curtain at how a hospital floor actually operates, specifically regarding delegation traps.
This is a huge testing point.
Oh, absolutely. If you've ever been in a hospital, you've probably noticed a whole team of people coming in and out of your room. There are strict legal frameworks governing who can do what.
It all comes down to scope of practice and protecting patient safety. Registered nurses, or RNs, are uniquely licensed to perform tasks that require clinical judgment and complex physiological analysis. This means they must handle all initial patient assessments, all medical teaching, and the care of any unstable or unpredictable patient.
Meanwhile, unlicensed assistive personnel, or UAPs, handle standard routine care. But the trap is when a task seems simple, but actually hides a complex assessment.
Let's say a patient's oxygen saturation drops and the RN places them on supplemental oxygen. 15 minutes later, someone needs to check if the intervention worked. A UAP is allowed to take vital signs on a stable patient, but they cannot evaluate a newly oxygenated patient.
Because evaluating that patient isn't just about reading a number on a monitor. It involves looking at their work of breathing, assessing their mental status, and analyzing their skin color to see if the underlying pathology is resolving.
Precisely. That requires clinical judgment, which falls strictly under the RN's scope of practice. Similarly, a UAP cannot interpret an arterial blood gas lab result or administer any kind of medication.
Speaking of arterial blood gases, or ABGs, before we synthesize all of this, I want to quickly share a mnemonic from the guides that makes decoding those complex lab results incredibly easy. It's ROME, respiratory opposite, metabolic equal.
It is a brilliant mental shortcut. An ABG measures the pH, the carbon dioxide, and the bicarbonate in the arterial blood. When you look at the results, you compare the direction of the pH to the other values. If the pathology is respiratory in nature, the pH and the CO2 will move in opposite directions. For example, in respiratory acidosis, the pH drops and the CO2 rises. They are opposite.
But if it's a metabolic issue originating in the kidneys or gut, the pH and the bicarbonate move in the same or equal direction. In metabolic acidosis, the pH drops and the bicarbonate drops right along with it. Rome instantly points you to the source of the problem.
It saves critical minutes when diagnosing a deteriorating patient.
Okay, it is time for a rapid review before you walk into the exam. Synthesizing everything we have unpacked today from this massive stack of materials, a few core truths stand out. First, airway always dictates priority. Second, your brain will panic before your body turns blue, so look for restlessness, not just cyanosis. Third, we have to respect the hypoxic drive in a severe COPD patient. Treating them with a flood of oxygen can be far more dangerous than the baseline disease. And finally, hospital logistics and delegation rules exist because clinical judgment cannot be automated.
If we connect this to the bigger picture, the respiratory system is a marvel of biological engineering. It balances on a razor's edge of pressure gradients, chemical thresholds, and immune responses. Understanding these underlying mechanics isn't just an exercise in memorization. It is the fundamental key to recognizing subtle shifts in real time. That deep comprehension is what allows medical professionals to intervene effectively, preventing a minor physiological glitch from snowballing into a catastrophic systemic failure.
That is a phenomenal way to frame it. To leave you with a final thought to ponder, the pharmacological guides briefly touched on the frontier of respiratory medicine, specifically regarding biologics and monoclonal antibodies like omalizumab for severe asthma. These drugs actually intercept the allergic antibodies in the bloodstream, neutralizing the threat before the airways even realize they are under attack. As medical science rapidly advances, creating hyper-targeted DNA-derived therapies that shut down inflammation at the genetic level, it raises a fascinating question. Are we approaching an era where mechanical ventilators, severe COPD exacerbations, and chronic airway remodeling become relics of a less advanced medical past? Will we soon treat these mechanical failures purely through genetic and chemical intercepts? It is a remarkable possibility to consider, and certainly something for you to chew on until our next deep dive.
Reassure yourself that respiratory questions are completely manageable if you remember the core rules. Airway first, oxygen first, early signs matter, and safety always wins.
This is Nurse Alyssa and Dr. Karim from NCLEX-ReviewPro. We'll see you in the next PodClass.